This conference will now be recorded.
So this is the high-risk recurrent and advanced prostate cancer group for today, September 14th. And this is Rick Davis. I know I normally don't lead the group today, but Peter was kind enough to switch with me last week, so I'm taking over Peter's responsibilities. Next month, we'll all be back to normal. For those of you who have not been on this call before, we do record it, largely because a bunch of people want to go back and re-listen again, and there are a lot more and more each month, each week, I should say, who listen later on because they cannot make the meeting, and they like to come in later and they like to listen. If anybody's uncomfortable, just let us know ahead of time. We'll find a way to shield you appropriately on the call. It shouldn't. We would never want it to stop you attending. So with that said and done, I see one new name which I have not seen before, which is Maria Andazunas, and I will come back to you in a second, Maria, because usually what we do, if you're willing, is we try to give you priority on the call. You don't have to take it, but we really want to offer it to you and to hear about the situation that you're calling about. And so we will come back, but before I do that, I am going to run through and see how many people would like to take some time tonight. And that way it'll give us a good idea as to how long we can spend with Maria. So let me start. I'll go down my list, and and I don't take these names as you appeared on the group. I take them as I see them and I get them down. So Jake, anything for you tonight?
Nothing for me. I will have a blood test tomorrow and find out where my PSA is, but nothing tonight. Thank you.
Okay. Les Shelter, anything for you tonight?
Maybe a quick one, yes, thanks.
Yes. Okay. Jim Marshall, anything for you tonight?
Negative.
Thank you. Dennis Correa, anything for you?
A quick update, Rick.
Okay. Paul Frieder, anything for you?
Nothing for me tonight, thanks.
Ted Healy, anything for you?
Nothing either, Rick. Thank you.
Bruce Bocian, anything for you?
Yeah, I have a couple items.
Okay. Rusty, anything for you?
Not this week, thank you.
Alan Moskowitz, anything for you?
Yes, I need a few minutes.
Okay. Peter Kafka, anything for you?
No, I'll yield to Carl and Al Latimer. I want to hear their stories.
Well, when you're done yielding, is there anything that you would like to raise yourself?
Not till next week.
No, not till next week. Thank you. Okay, Larry Fish, anything for you?
I'm yielding as well.
Oh, you're yielding as well.
I want to hear what Carl has to say.
Okay.
I know he's been through God knows what.
Right. Tom Price, anything for you?
No, Rick, thanks.
Carl, I know we got something for you. Steve Saft, anything for you? Mr. Saft, where are you? There you are. Turn on your microphone. Turn on your microphone.
Right, I know that. Yeah, if there's time left, I can update, but my schedule really starts at the end of the month, so I can talk next week if we run out.
Okay. Ben, anything for you?
Mike.
Where did Ben go?
Your mic's going off, Ben.
You're not sharing your food with it, maybe.
Yeah, and I can't even see him on my screen.
Yeah, he's there, but on my screen, he's below Paul Frieda.
Well.
Walking, if mic is on.
Oh, there he is. Now I see him and your mic's on, Ben.
We can't
hear him.
It's not coming through.
Okay,
Okay,
nothing.
nothing.
And you're not coming through anyway, so sorry about that. John Vanderberg, anything for you?
This is my first meeting with you all. I just might do a brief introduction. That's all. Thank you.
Oh, I thought, well, I know who you are. I thought you'd been in the group before, so thank you for reminding me that it's your first meeting. Definitely. Absolutely. Al Latimer, we know we want to hear from you. And Dennis McGuire, we know we want to hear from you. I know Russell doesn't have anything. Len, anything for you?
No, Rick, thank you.
Jim Ward, anything for you?
Nothing for me tonight, Rick. Thanks.
Okay. If only it's 15 seconds, Herb has an update for us. I know that. Did I put Peter down twice? Yes, I did. Jim Jeffries, anything for you?
I'm good tonight, thank you.
Jeff Marchi, anything for you?
Not tonight, thanks.
Okay. And Jimmy G, anything for you?
The only thing I can talk about is how good I feel, and no one needs to hear about that. So I'm good.
Okay. Oh, and Tracy's now on. Tracy, anything for you?
No, I don't think so.
Okay. All right. We got through everybody, even the latecomers. We got a bunch of people that need some time. So we're going to have we'll have about 45 minutes for the new people. And we'll start with Maria, and then we will go on to John Vanderberg. Maria, are you there?
Hi there. Yeah, sorry, I'm making dinner.
You're making dinner. What are you making for dinner?
Beef stew.
Oh, okay. Sounds good. Sounds good. Now, who are you here for? Who's your care partner?
My husband, he can't be here, but I'm going to relay information to him. He is stage 4 metastatic prostate cancer for the past couple years. He was diagnosed at 52. So he's had the prostatectomy, and I think.
So let me do this. I'm going to ask you a bunch of questions, okay? And we'll get most of the information that way, and then you'll figure us in. What's your husband's name?
Jeff.
Jeff. Okay. And how old is he now?
54.
Okay. And where do you guys live?
We live in Illinois, a suburb of Chicago.
Okay, so you're in a Chicago suburb. You've got some company here. We got a few of you. I don't know how many tonight, but we've certainly got a few of you. And you say that he had a radical prostatectomy 2 years ago. What was his Gleason score and his PSA level when he was diagnosed? Do you remember that by any chance?
I do. He was a 9, a 4, and a 5 were the two numbers, 4 and 5.
Yeah.
And I believe PSA was just about 18.
Right. Yeah, that all makes sense. And where was he first treated?
At what hospital, you mean? Or what?
Yeah. What hospital, what urologist? I mean, who was the first person he saw?
He saw a urologist here at Palis. It was a community hospital.
Okay.
For the biopsy, he saw, he's had about 3 or 4 doctors.
And where where did he get the radical prostatectomy?
He had it done here at the local hospital, Payless Hospital. We went to University of Chicago.
Okay.
For a second opinion, and their recommendation was similar to what his local doctor urologist suggested. So since it was close, we stayed locally then to have the surgery and for treatment.
And did you see a urologist at U of C, or did you see a medical oncologist?
I believe he was a medical oncologist, Dr. Smolowitz.
Yes, we know him.
Yes.
Okay, so you've seen him once already. Okay.
Yes.
Great. I'm assuming with a 5+4, they did a bunch of scans even before he had his radical prostatectomy. Did they see anything in those scans?
They did. He had the PET scan.
Yep.
And they saw the a bone metastasis in the pelvic bone.
Okay.
Spot.
And so they saw a bone metastasis, and then you and your husband and the urologist and Dr. Schmulowitz all decided he should still do the radical prostatectomy, correct?
He had the prostatectomy first before the scan.
Ah, okay. So they didn't see that before the scan? Did they not? Did they scan him before?
They did they did just a CT scan, a pelvic scan. Yeah. They didn't do the PET scan until after, once his PSA was rising after surgery.
That's when they found that post RP. Okay, yeah. With a more detailed scan. I've got you. So, what treatment did he have when they saw this bone scan?
He had radiation. He had the Firmagon. He's on Zytiga.
Yep. Bone strengthener? Is he on yes. Something?
Exgeva?
Yeah. Okay. And what's his PSA done since the prostatectomy?
It was up when after 3 months after surgery. Yep. Once he started on the Firmagon and the Lupron, it's been undetectable for the past year and a half.
That's dynamite. Okay, so right now he's on Firmagon, Zytiga, yeah. And he's undetectable. Got it.
Undetectable, right?
Undetectable.
And he gets his PSA every month.
Okay. And who is running his care right now? Who's his main doc?
His name is Dr. Berger, Berger.
Mm-hmm.
He's a
go ahead.
Urologist.
He's a urologist. Okay. Well, the guys will have some comments on that, but
I believe.
He seems to be doing the right thing. Have you done any genetic testing?
Yes.
Or has he?
When he first was diagnosed, But I'm sorry, what?
I didn't mean you. I mean, has Jeff done any genetic testing, either for inherited mutations or for mutations he might have made himself?
Yes, he has had the genetic testing.
Uh-huh. And what did they find? Anything?
I'm not sure. I'm not sure the results. They didn't find it that it was hereditary.
Okay.
If is that?
Yeah, that's part
I don't
of
really.
And
I'm not sure about all the.
Yeah. So he's got no inherited. and you're not really
No.
sure. Do you know if he did the test to see if he's made any mutations other than the inherited?
I believe he did. I'd have to find the results and look at them.
Okay, but so that's something we can talk about. And then two small things. One is, how did you hear about us?
I heard about you from a support group that we go to at it's called the Wellness Center in LaGrange, Illinois.
Okay. Is that an us two group?
No. Mm-mm.
Oh, okay. Well, I'm glad you heard us. And do we have your contact details? Have you given us your email so we can send you a reminder before each meeting?
Yes, I do get the emails already.
You do already. Okay, so you're on our list already. So
Correct.
you've signed up and you're on our list. Okay. Excellent. Now, I think that that's probably enough information. So I have some thoughts, but I'm just going to turn it over to some of the guys here to talk to you a little bit. Do you have any specific questions you would like to ask us?
Not any specific questions. He's coming up on his 2-year mark, and I believe his doctor is going to stop the Zytiga and the hormone therapy. I was just wondering if any of the gentlemen have had any experience with being on everything and stopping it.
They have. They have, and one of the things you might want to do also is we record these, as I mentioned, and you might want to listen to last week's recording, because I think it was talked about in some length, or the week before. We talked about men who had been on intermittent and their experience. It might have been 2 weeks ago that we talked about men who were on intermittent. We have one person that's joined us on the phone. I bet that's David Muslin, as well as us seeing him. It is, isn't it? Yes. Okay.
It is, Rick.
We got you. Okay. So, Mr. Muslin went to see Dr. Shmulewicz this week or last week as well. Who would like to start off talking either about whether it's a good time to take a break, not a good time to take a break, and anything else that came up from Maria? Don't be shy, guys. Come on.
I can go, Rick. I spoke to Hussein about it today, and I spoke to Shmulewicz about it on Thursday, so I can give you a little bit difference of opinion. So just to bring everybody up to date, 60 days ago, I've been on Lupron for about 18 months, and about a year ago I started on what was the drug that turned me upside down, Rick?
Enzalutamide.
Enzalutamide, got off enzalutamide and got onto abiraterone. And I was just feeling pretty shitty about 2 months ago. I dropped the abiraterone, stayed on the Lupron, and I have to tell you, I feel way, way, way better today. And I went to see Shmulewicz to see what his thoughts are about it. And he really pointed out to me, he says, there isn't any great answer. It really depends on the patient and how he wants to live his life. He used the word nuance, and it's a nuance with every patient. And then I went to see my friend Dr. Hussein today, and I asked her about it, and she says, if I were you, if you didn't do well on Abby, she suggested maybe getting on darolutamide, which is different than what she said 6 months ago. She said having a second line drug to fight, to keep your cancer down and keep your PSA undetectable, she said that's a good thing, rather than being risky and getting off the drug. So I've got two different opinions from two I think, well-respected doctors, and I think it really goes back to what Shmulewicz said. It's about a nuance in what we want to do individually. And I don't know if that helps or makes it more confusing, but that's what I've experienced in the last week.
One thing I meant to mention to you, Maria, is that we have a special group for men under 60, which Jeff might be interested in joining. It meets the second Thursday of every month. And I don't know if you're signed up for that or not. If you want to send me your email in the chat window, I can check and make sure that he gets a reminder for that meeting too. But it's a really good meeting, especially for the younger gents, because a lot of times there are different issues to the older guys, and there's probably 3 or 4 of those guys that are on this call right now. Anybody else got any ideas or thoughts as to whether what they might do if they were in Jeff's shoes?
Rick, can I add one other thing that Shmulewicz told me that I hadn't heard before? Sure. Shmulewicz said that being on ADT, you've got it's a 3-year median or average for most men before it turns resistant, castrate resistant. Right. And he said, even if you take a break in between, that 3 years really doesn't change. He says it's about 3 years. You know, some guys could be much longer, some guys are going to be shorter. And he says, and whether you take a break or not, whether you take a break or not, right, it doesn't really change. So just sharing that.
Yeah, that's really interesting.
I made it 15 months on Zytiga, and then my PSA started to rise and Mets appeared.
Hold on a minute, Steve, because I want to just clarify something with him. Now, is that 3 years from LHRH alone, or is that 3 years with a secondary anti-androgen?
I didn't ask that question specifically, but he used the word LHRH. He didn't talk about with the second line drugs. I don't know the answer to that, Rick.
Right. So that's, I just wanted to raise that, Steve, because you know, there's a nuance here as to whether you're going to get 3 years, whether you break or you don't break, and then go on to a second line anti-androgen, or whether you're going to go, whether you're not even going to get 3 years. I mean, we know plenty of guys that haven't gotten 3 years and then they've started the anti-androgen. So Jake, go ahead with your comment for Maria.
Okay. Yeah, I was just going to suggest that because Jeff has a very low PSA right now, he might want to ask his doctor about getting a Provenge treatment, where they basically extract your blood cells, they process it, and then they reinfuse it into you. And it does have some known benefit, especially when you're early stage.
The problem is that you've really got to be castrate resistant. You've got to have 3 successive rises in your PSA to do that.
Oh, I did not know that.
Yes. I mean, that's what makes you eligible. If you remember years back with Lupron Jim, and he actually went off the drugs to force his PSA up, and they bought that, and he got Provenge many years ago. So so that's really, I mean, it would be a good strategy. Anybody want to talk about the quarterback doctor?
Yes, I'd like to say something about that, Maria. My name is Peter. Most of us are in Jeff's situation, where most of us are Gleason 9s, and we've certainly been there and been working with this in different ways. At this stage, you probably want to have a medical oncologist that specializes in prostate cancer, someone like Schmulowitz, as your primary doctor, not just for a second opinion. And in this day and age of telemedicine and so forth, I mean, you don't have to drive to Chicago for appointments all the time. You can do a lot of this on the phone or virtually. But he's probably going to be in the long haul. And these guys specialize in drug therapy and just the overall treatment protocol, because there's some complex stuff in Jeff's future. And you want to have someone who's really on top of it. I'm not saying that your urologist is not qualified or not up to speed. I don't know him, but you probably want to switch over to a medical oncologist, particularly a genitourinary medical oncologist. And since you've already had an association with Schmulowitz, that would probably be the easiest thing to do. He's well respected and on his game. So most of us do that. I live in a remote place, so my doctor's in California and I live in Hawaii. But I've been able to, for 7.5 years, to manage doing it from a distance or visiting them in person. It's doable.
Anybody else have any comments on the urologist versus the GU medal?
I mean, I second what Peter said and thirded and fourthed. I think you have to have somebody that only does prostate cancer or genitourinary, the same thing as an oncologist, and goes and sees all the things that the various conventions and talks to other people that have the same specialty. I think it's critical for care.
I'm with Kaiser, and they, when you're advanced like this, they take, your urologist is no longer involved. They give you a GU oncologist, and that's how you go. I've been for 4 years, and I have never met her personally. There is no need, even though she's only 18 miles away. She has all my results. She knows everything. I had a video conference with her yesterday. You really don't ever need to see your GU, firsthand, in live.
I mean, if there's one takeaway from me here, Maria, I would endorse what the guys say, that we don't like to see urologists treating men whose cancer has advanced to the point where Jeff's is, because we feel that by and large, the urologists are just not up to speed. They don't spend enough time in the research of advanced cancer. It's not their field. They are really there up and through the surgery. And after the surgery, and I don't mean to sound cynical, but a lot of these guys will stay in because they want to give that Lupron shot or the Firmagon shot every so often, because it's a really great cash cow for them. What we would rather see, I know if I was in Jeff's shoes, I'd shift my care to Schmulowitz. And we like him, by the way. He's one of our preferred medical oncologists in the Chicago area. And if you're comfortable with him, I think you're going to do a lot better off in the long run, especially at the point when the PSA starts to rise. And unfortunately, that is the likelihood. That doesn't mean to say there aren't a whole bunch more treatments available for him. There are. But the person selecting those treatments or discussing those treatments should be Schmulowitz and not Dr. Berger. Although I know one of the other guys on the call mentioned that they have another friend who sees Dr. Berger. I'm sure he's a very good doc. But he's now at a point that's really beyond his knowledge, although most urologists won't agree with that statement. So, what do you got to say? Miss M.
Thank you. I do appreciate all the suggestions and comments. Is there a Dr. Hussein that someone mentioned that's at University of Chicago?
She's at
Dr.
Northwest. She's at Northwest.
Northwestern.
Yeah.
And that's a female, I believe, right?
And that's the female.
Okay.
And yes, we know her well. David Muslin, who was the first person to speak to you, knows her very well. Some of our other guys know her well. If it were me personally, I would probably pick Shmulewicz over Hussein. Or I might pick a different doctor at Northwestern, because our experience with Dr. Hussein, while she's incredibly well recognized, is that she's erratic and she's stubborn. And she's not as flexible as certain other docs in her treatment choices.
Okay.
And for example, David mentioned that today she said to him, well, we can go on this drug called darolutamide. We like that drug a lot. The men like it. David almost went down on his knees and pleaded with her for that drug 6 months to a year ago, and she almost threw him out her office for asking for it. And now here she is today, and she's saying, yeah, why don't you try darolutamide? I mean, it doesn't make sense. So
no,
but yes, she is a well-known name. But I think we'd probably suggest either Van der Weylen, who works for her in Northwestern, or Shmulewicz at Chicago, or Stadler at Chicago. Shmulewicz is fine because he's already seen Shmulewicz, and he should see more than one. Let him make sure he picks somebody who he feels comfortable with. How's your insurance, Maria?
Well, I'll have him listen to the. Pardon me?
How's your insurance?
Our insurance is with Northwestern.
Okay. Well, again, he's a bit of an.
It doesn't matter though.
Okay. Well, Shmulewicz or Van der Weyler is a good option. I mean, we've had a couple of people on this call see Van der Weyler. He favors intermittent. He suggested to one of our guys that he should go on intermittent when this guy never thought it was ever going to be offered to him. So,
And Rick, this is Jim. Isn't Hussein kind of, she's a little reluctant to support intermittent as well? I mean, haven't we kind of heard that?
Yep. She used to be originally, but now she's kind of switched. Right, Mr. Muslin? Anything to say on that one?
Correct, because that's what the data says. She's focused on the data.
Yeah. She's focused on the data. So we need to move on. We've got at least one other new gent and possibly two more. I don't think we're going to get to all of the new men tonight. I'm sorry. We like to try and give you time. Maria, listen again. Write to us if you've got any questions. Come back next week or the week after, but come back, and we're here to help you.
Thank you. Thank you for your time.
Pleasure. Next up is Jim Vandenberg, who Jim, we've talked for some time. Was it Jerry Deans that got you involved, brought you to us?
I think you're speaking to me, Rick. It's Ravi Subramanian was the one who recommended.
Oh, that's right, Ravi.
Yeah, Ravi.
That's
yeah. So
right.
I could do a quick rundown that may be useful. And first off, I appreciate the opportunity to hear the group of folks here on your experience. So at age 52, I was diagnosed with Gleason score of 7, 4.3 3 and had a radical prostatectomy. And I was in remission for 10 years. And then in 2018, it came back with my doubling time of about 9 months. My PSA got up to about 2, and I had radiation therapy here at Duke, which is where I'm treated. I'm in Durham, North Carolina. Right. And I had 33 radiation treatment days there, 2 grays a day. And my PSA dropped down, and then it went right back up. And so I went back and had a PSMA scan up at Memorial Sloan Kettering in New York City, came back and found 2 spots that were outside of the region that had been irradiated. Kind of my 2 jelly beans here on the left side and the right side. There are two places about the jelly bean size on each side. So my oncologist is Andrew Armstrong here at Duke. And so I've been on Lupron for a little more than a year, Zytiga for a little bit more than a year. And I have had my testosterone level is around 20, has been stable since then, but my PSA is non-detect. I have not had any genetic testing at all. And I would say that I was taking 1 gram a day of the abiraterone, and back in January I was concerned because I was having just a lot of side effects, more than I was accustomed to even after being under for some months. So I dropped down to 3 pills a day, 750 milligrams a day. And that has been better, but I've had significant muscle loss, stamina has declined a lot. And my most recent meeting with Dr. Armstrong, he recommended much more exercise. And so I'm now exercising 5 days a week at a gym here. He really pushed that a lot, just exercise. I was ready to sort of drop down even further, and he made it very clear that I was, in his mind, high risk to very high risk because I have 2 active metastatic locations, and that I should just stay on based on the Stampede study for 2 years. That was his recommendation. That's what I've decided to do. So I guess since last summer, I'm again about 14 months into the Zytiga and the Lupron. I've had 3 Lupron shots, and I'm tired of it. I have a lot of fatigue, just tiredness. But the exercise I think will help some, with especially the muscle loss. And I also retired from my job, which I think has helped with the stress level as well, and just have more time for exercise and doing other things. So Rick, I think that captures many of the questions that you had, but you may have some that I missed.
No, it was pretty good. I was writing away like crazy here. Did you say that when you were first diagnosed at 52, 4+3, that you had a radical prostatectomy?
Correct. That's correct.
Yeah, that's what I thought. And then nothing happened for
10 years.
10 years, no recurrence for 10 years. So you're now 65?
That's correct, 65. Yeah, that's right.
Okay, so the first thing I really would like to do is get some testimonies for you around the benefit of exercise. Who would like to talk to that?
Don Price can.
Okay, thank you. Go ahead, Commander.
And I was 4+3 also, and this was about 7 years ago, and was 18 months on a combination of Firmagon and Zytiga, and hit the gym a lot, had a personal trainer, and I think that's very important because for me anyway, because left to my own devices, I would not push myself. And there's no question in my mind that 18 months later, I was significantly stronger and as energetic when I finished than when I started because of all the weight routines that I did. And then I continued to, I had run before and bike before. I continued to do that during the 18 months with a running group. So, left to my own devices, I probably would have quit, but having other people there was an incentive to show up and continue to exercise. So I can't enough tell you how important all that stuff is.
Yeah, Don, I appreciate that. I actually just started with a trainer about 3 weeks ago for that very reason, is that I wasn't focused on what I needed to do in the gym. So it has helped me to kind of push myself and have structure to it, which is a good thing for me. So thank you.
Hey, John, this is Bruce, and this goes to everybody. I sent Rick an article today or yesterday, I believe it was, regarding supervised therapy for people on ADT and the benefits of it. It's an excellent article. Rick, I don't know if you can post that to the group or not, but it really tells you about the benefits to it. I wanted to see if, in fact, Medicare would cover physical therapy for someone on ADT. I did reach out to Medicare.gov today. I had a chat with somebody, and at the end, basically what it came down to was if the doctor prescribed it as necessary, then Medicare would cover it. So that's where it stands right now. Now, the other thing that I found out today, because I got a mailer from my supplement insurance with United Healthcare, which is my Part G. I didn't realize this, but I was qualified for a free gym membership in any of the gyms around my area. So I went to the local YMCA, which is just fabulous. I walked in, I gave him my authorization code, and I now have a full-time gym membership there where I can join classes and things like that and exercise and do the whole 9 yards. But I'm not on ADT yet, but there's a possibility I may be going on it. I got a meeting with Stadler's, Dr. Stadler's radiologist tomorrow. Stadler said in my case with my PSA being that low, that he's not dead set on ADT with the radiation for me. He feels that I'm actually kind of low and that radiation would be fine without the ADT. That's his feeling. I'll talk to his radiologist tomorrow. I've got an in-person meeting with him at the University of Chicago. So that's where I'm at. But if Rick, if you want to share that article, it's excellent and says some great things.
Yeah, you sent me a PDF, so I can't provide a link to that. I know Herb maybe, I saw Herb looking away. I copied Herb already on that article, so he may be tracking the link.
I'm typing away because I hate to contradict our brother here, but that article really was not that strong in terms of supporting anything. It was a literature search, not a trial. They describe their evidence as, quote, moderate quality, which is really not strong at all. That supervised evidence helps. They didn't have a control group of either no evidence or no exercise or unsupervised exercise, which we can all do by ourselves without a trainer. So in my humble opinion, I think we all agree exercise is good. I'm not going to ever say it's not. It's helping me, but I don't think that paper made a strong case. And I'm sorry, Bruce, that's my opinion.
You know, what I would say, what I'd say about that, and we'll try and find, Herb, any chance you can find the link to that?
No, I can put it up right in a minute or two.
Yeah, but here's what I want to say.
But I don't really think it's worth looking at.
Okay, but so let me say this. This is the point I want to make. I don't think you'll find a prostate cancer group anywhere in the country that is as committed to promoting exercise, John, as this one.
Okay, good.
I mean, we just have so many people. Of course, everybody's decided to be quiet right now, but I could pick out almost anybody on this group, and you'll find that they're exercising and they started exercising. And I forget, in our survey that we did, how many people started exercising as a result of this group? Do you remember?
Like 30 to 40%.
Right. So we are very committed to exercise. So it doesn't really matter a lot to me what the survey says, because we know it makes a difference. Anecdotally, we hear it from so many people. And so the take-home message is, yes, Dr. Armstrong was right on the money. you do need to start exercising and stick with it, and it's going to make an unbelievable world of difference. And when you feel tired and fatigued and say, how the heck can I exercise when I feel so fatigued, and you go out, and even if you get on the treadmill for 15 minutes or walk for 15 minutes, you're going to feel better at the end, and you're going to say, wow, this is totally contraindicated. This is totally contraindicated to what I expected. I didn't think I'd be able to do anything. Now I feel better for it. And this is a repeated experience time and time again. The second thing that I want to say is that God bless Bruce for finding this article, because, and I don't know why, I've been involved in promoting exercise for cancer since 2008 or 9, and started a cancer exercise program at UCSF. That said, I don't know why I never thought, why don't we ask our GU medoncs to prescribe a physical therapist? Now, one reason might be that physical therapists aren't exactly what we want. We really want exercise trainers. Right. And physical therapists are not exercise trainers. But now so many physical therapists are in sports medicine practices that you can probably get away with a combination. And one of the ideas that I just had today is I'm going to go to Dr. E, to Eleni Efstathiou. I'm going to say, Eleni, if you haven't done it, can you prescribe a physical, a PT, a physical therapist for one of your ADT guys? And I know she's going to say in a heartbeat, I'll try it. And I'm going to try it with Alicia and ask Alicia to do it. And I think that if we can gather up enough steam through all of the guys that are in here, and we all go into our medical oncologist, if we have one, whether it's Shmulewicz or Hussein or whoever it is, and say, we need help with our exercise, please will you prescribe a physical trainer? I can't imagine any of them are going to say no. Well, maybe Hussein. because the evidence is as good as it should be, right, Herb?
Well, I mean, I think I actually just found a paper which did what I thought that somebody should do, and I will post it. Where actually they did a randomized trial of giving people with bone mets physical exercise prescription or not, and showing that in fact the people who were prescribed exercise did better. So I'm not arguing that exercise isn't good,
right?
But I'm just saying that we've got to look carefully at the data.
Right. And in other words, this may not be the best paper to take with you to give to your medical oncologist, is what Herb's saying, but maybe we can find some other papers that you could take. And most good GU medoncs, like Dr. Armstrong, know that how important exercise is. And Steve Saft is posting, what about the guy that has done 23 docetaxel treatments and does a long walk after each one? Well, yeah, that's Ken Anderson. He's not on today, but I mean,
isn't that very unusual that somebody really can tolerate that many chemotherapy treatments?
Yeah, but that's a whole nother issue, Steve. That I don't. That's a side issue I don't want to get into right now. But you know, what I think is more unusual is that somebody's able to go hike 15 miles the day after they have docetaxel. Whether they have 6 or they have 20, that's not common, and Ken can do that. But you know, I guess we sort of need to move on. But John, is there anything else that we can
there's
help?
There's one other fatigue factor that you haven't mentioned, and that is when you get hot flashes. I know that when I was getting severe hot flashes, I would get severe fatigue right before them, and it would tire me out after I had a bunch. John, are you getting a lot of hot flashes?
Yes, I am. Yeah.
All right. One thing you should really do something about. Have you done something about them yet?
No, nothing. Tolerate it.
All right, because I take a Depo-Provera shot every 3 months, and with just Lupron, I was getting no hot flashes at all. They're extremely mild. I'm on Zytiga now, so I'm getting hot flashes. I'll get as many as 15 a day, usually closer to 10. But I have found that as long as I get the Depo-Provera shot and wear the Ember Wave device and hit it, it's a refrigerator you put on your wrist, and they're looking for beta testers right now. You can get one for free. And between the Depo-Provera shot and the wave, I don't get the fatigue. I don't get a real hot flashes. I had one today because I didn't have the thing on or I couldn't turn it on. Had a really big one, but I don't get any big ones. And it also has a night mode, which prevents the night flashes. You should really look into getting one of these for yourself under they're doing a study.
Let me interrupt you, Jeff, just for the sake of time, and you make a really good point. John, I know you've been on our list for a while. I remember when I put you on. So you've been getting our reminders now for some time.
Right.
If you've still got them, go back to last month sometime, and you'll find in those reminders a trial for a device called EMBR, Ember, and a flyer attached to the reminder. And all these guys that are waving their wrists at you, if you noticed, are all wearing these Ember devices, and they're making a difference for them. David Muslin, Jeff Marchi, Herb Geller, I don't know how many others. And they make a big difference. And the fact is that one of the reasons you're so fatigued is because you're getting woken up way too many times at night, and most of the time you don't even know you're getting woken up.
Yeah.
And these will allow you to get better sleep through the night.
Well, that's a great idea, because I do get hot and cold all night long. All night long, I'm hot and cold. So I know we're about out of time, but I just wanted to mention that I've had 2 rounds of radiation that is a total of 58 days through my belly. It's causing a lot of continuing GI problems, even though I haven't had it for 6 months. So maybe another discussion. I'd like to see if people have any suggestions, because I take kefir every day. I don't eat any nuts. I don't eat any grain or anything like that. Just diet changes, but I still have GI issues. So, suggestions about that would be welcome in the future.
Keep coming back. We'll definitely talk about the GI issues. We'll talk about this this radiation treatment that you got. You said you got 2 lots. Did you have radiation right after your RP or not?
No. It was 10 years later.
10 years later. And why did you have 2 different sessions, 2 different lots?
First time it was focused on the prostate bed.
Okay.
But that was before the PMSA or PSMA study. The study came in and they said, okay, you've got a spot over here on the left, a spot on the right. We're going to get those spots, 2.2 grays. We're going to get everything in between. Everything in between, I think, of 2 grays is really what's affected my GI.
I am surprised at Duke that they didn't do a wider focus pelvic girdle when they got you the first time. That surprised me.
Yeah. So.
But anyway, come back next week, and then I'm going to have to apologize to Joe Donardis. And I think, Richard G., you've been with us before, have you not?
Yes, I have, Rick.
That's right, I remember. But Joe Donardis, are you there? Speak up, Joe. We can see your microphone's on. Can't hear you. Joe, let me just say, we've got to move on to get around a lot of people today, but please come back next week. We'll make sure you have priority. We know that Jim Barnes referred you. We know you got a Gleason 8 situation. If there's anything really pressing, then let us know. You can call me during the week, or Jim Barnes knows how to get hold of me, or somebody will put my email in the chat window, rd@ancan.org, and my telephone number. And if there's anything between now and next week, feel free to reach out. If not, next Monday night, when you'll have the professor in the chair, and he'll handle you with aplomb, as he always does, and we'll give you the same treatment that we just gave to to John and to Maria.
I'll handle them with a grapefruit if I ever got one.
Oh, you'd rather have a grapefruit than a plum, is that right? Very good. Okay. All right. So let me get on to getting around. And since everybody is so anxious, I think we'll definitely start off with Carl, although try to keep it short, Carl, because we've got a lot of people. And then from there we'll go to Al Latimer and Dennis McGuire. And then we'll see where we go after that. So Carl,
okay. Well,
tell us how you're doing.
Everyone fasten your seatbelts.
Okay.
I have a diary, a chronological order of what I've been through over the past month, and I'll talk very quickly. So day one of my trial at Weill Cornell was on August 12th, where I had an infusion of actinium, Keytruda, and also started daily Xtandi. On day 8, 1 week later, I had my first weekly meeting with the trial's principal coordinator as previously scheduled. No issues, no side effects. I said, wow, I feel great. Next weekly appointment was canceled because of that. 3 days later, oh my God, what is happening? Experiencing severe side effects, fever as high as 103, extreme fatigue, so weak that I slowly dropped to the floor and could not find the strength to get back up for 2 hours. I just sat on the floor. I had a real dark red itchy rash all over my body. The one thing that the doctor could do, he says, well, let's stop the Xtandi for now. And then 3 days later, I entered the hospital at Weill Cornell. I was there for 5 days. I started in the ER, where all patients initially start in lieu of getting admitted directly into the overwhelmed hospital with barely any beds available. Finally, 2 days later, day 16, I was put into a hospital bed, being treated for extremely low platelet counts. My platelets fell as low as 16, which is very dangerous. I had 2 infusions which brought my platelets counts back up by day 5 when I was released to 65, which is still pretty low. I have to say, as of today, I'm at 253, so I'm back. And before I was released on the 5th day, that 4th day, I was given a new partner in my room. And it turned out that this was a homeless man. They had his shopping cart with all kinds of plastic bags on the side of the room. The room was kind of starting to smell because who knows when he last had his shower. And at one point, he even asked me, he said, do you have an extra pair of underwear? I have nothing. So I gave him a pair. As I was leaving that day, I gave him my underwear. I gave him a sweatshirt. I gave him sweatpants, and I gave him some money. So after I was released, the doctor told me that my side effects were from an unfortunate combination of the meds and separately from some kind of infection I was fighting before entering the hospital. And fast forward several weeks later, back on the daily dose of Xtandi, platelets are back to normal. Fatigue is still, pretty strong. And my PSA, which I was hesitant to look at the results, but my PSA had dropped by 20%. So that was a nice thing. And interesting, our friend Alan Edel, who a lot of people know here, he had responded to my posting on mailcare.org, and I just wanted to share that pretty quickly because of my experience with the homeless man. And he said to me, he wrote to me, if you are Christian, Matthew 25, 31 to 46 is relevant. If you are Jewish, there's a midrash that the Messiah wanders the world as a homeless man until such acts sufficiently prove our worth. So I thought that was amazing, and maybe that's a good sign for me.
Wow. Alan Edel is Jewish, by the way, if you didn't know. So, what is your PSA today?
When the trial started, it was 35, and now it's 28.
So it's 28. And you're back on everything.
Right. Well, the only thing that they could take off was the Xtandi, because that's a daily medication. I am due next week for my 6-week infusion of Keytruda, which is on schedule.
So how many Keytrudas have you had so far?
1.
So is there any thought that this might have been a cytokine storm?
Not really, no. Tagawa mentioned that possibility, but he didn't believe so.
So he thinks that you got so sick because you had an infection when you first started the treatment?
Yeah.
And where was that? Where does he think that infection was?
Well, we just don't know. We just don't know. I was on Benadryl, and as I said, my fever was as high as 103, but it's resolved itself. The rash, I was given steroid cream, which has also been really good, and it has resolved the rash as well.
I'm just curious to know what other people think, and probably there are people on this call who know more about cytokine storms than I certainly do, and how they would compare that to the idea that there was serious. Okay.
There's an echo.
Yeah, we need to silence 04. We need to silence 04. Can Len or Herb, if one of you can take care of watching that for me, I'd appreciate it.
I got it, Rick.
Thank you. Thanks, Jake. I mean, any thoughts on this response that Carl had, and any thoughts on what you might do moving forward?
Why can't they figure out what the infection is? I mean, I think you told me you were tested for COVID, but was there any other specific tests for?
Yes, there were a number of tests, and nothing was conclusive, and it has resolved itself.
Right.
A so-called infection that resolves by itself without any antibiotics, that doesn't sound right to me. I think it's more to do, I don't know if you want to call it a cytokine storm, but ramping up of the immune system that caused the rash, maybe a little bit of autoimmunity going on there. The 103 fever is consistent with a cytokine storm. The fatigue, the overwhelming fatigue, that sounds more likely to me anyway.
I guess, Carl, my greatest concern at this point is we don't want to see you back in the hospital after another round of pembro, and obviously neither do you. And there are enough elements of what was wrong with you that are consistent with people that have had cytokine storms. And, you know, I'm always leery of principal investigators who don't want to give up. And maybe I should turn to our own principal investigator. What do you think, Professor?
I mean, I think there's always that, you know, they need a result. They need to keep you. But I do agree with Len. It certainly seems like an immune reaction. Fever, rash, very consistent. Whether it was cytokine storm, they should have actually measured. If you're on a clinical trial, they should have actually measured your cytokines to see what actually was going on. And Carl, you might just ask them if they did.
I'm trying to think, because they gave me so many different blood tests. Is that I don't know. I mean, what would the blood tests be called for that?
Well, I mean, it would be, you know, interleukin beta, things like that.
Isn't there a PK test that looks at the cytokines in your system? Blood test, something that's what they used to say to me when I was on the clinical trial.
I'm sorry, Stephen, what did you say? I didn't get the beginning.
They called it a PK blood test that I thought was, I don't know exactly what that means, but my impression was they were looking for cytokine reaction.
I can't speak to that. I haven't heard of it.
Okay.
But I definitely think, it's so, and yeah, but an infection can trigger an immune reaction also. So, for that, they would have had to have some evidence that there were bacteria in your blood, which therefore should also show up on some test.
Yeah, did they do a blood culture, Carl?
Yes, yes.
It was negative?
I would have to look it up.
So anyway, I thought this clinical trial only allowed you to get one dose of the Keytruda and that was it. Are you saying now that they want to give you another dose?
No, the trial was intended for the Keytruda every 6 weeks for up to 2 years. The only single dose is the actinium at the beginning.
Ah, yes, right, okay.
Yeah, it was the actinium. Carl, I think that if it were me, what I would do is I'd gather all of my results, all of them, and I'd go to one of that collection of doctors that you have put together better than anybody I know, other than Tagawa or anybody associated with Tagawa, and present the data to them and say, can you look through this carefully? What do you think this was? And do you think I should go through another round of pembro? And have them focus on some of the questions. Maybe Herb will give them to you, or Len. The tests. Did they measure my cytokines? Did they do this? Did they do that? Did they do the other? What we're trying to do is to take out the bias of the principal investigator. Because I don't think any of us would forgive ourselves if, God forbid, you had another round of pembrolizumab and 15 days later you're back in the hospital again. And this time it might not be Jesus that comes in. We don't know who's going to be around next time. So, but I think you owe it to yourself to do more than just take Tagawa's word that this was an infection. That's what I personally would do. Anybody else want to comment on that strategy?
Yeah,
This is John.
Carl, I might have asked you this before, but I know my oncologist had me take a mouth swab test for UCLA to see if I could tolerate Keytruda. I haven't done it yet. I haven't done Keytruda yet, but I got the results back that said I can tolerate it pretty well. There is some kind of test available. Maybe I asked you that already, whether you did that.
No, I haven't. No.
Carl, this is Al Latimer. Dr. Scholes also had me do that mouth swab before Keytruda, and he told me I was not eligible because of it, because my test came back, I don't know, positive. I'm not exactly sure. He just told me I wasn't eligible. So I'm not exactly sure how that fits into what you did, but like Peter, Scholes had me do that test too at UCLA.
Is there a specific name for that test other than a mouth swab, or that they should know what that is?
I've been looking for my paperwork. I can't find mine, but as soon as I find it, I'll email it to you.
Great.
Tagawa should know about it, Carl. Just ask him.
Yeah,
Carl, I guess, if I may.
Is that a test that's trying to measure your level of PD-1 or anti-PD-1?
No, it's a test that supposedly can tell them if you will have serious side effects from Keytruda.
Okay.
Or not.
But but this is I think the reason we're spending the time to air this with you, Carl, is because we really want you to do your due diligence before you get another round of pembrolizumab.
Sure.
If I may add, the fact that you didn't have a room for 2 days, when did they, and you were not feeling well, and I'm pretty sure you were not at your best. You and I spoke in between meetings here. And it seems like, whether or not Takawa is doing all that he could, it seems like there's a possibility that you didn't get the kind of attention you should have for such a serious set of side effects, if I may.
Yeah, I mean, the first 2 days, the first day was in the emergency room, got there at 3 o'clock in the afternoon. 2:30 the next morning, they moved me into another part of a staging area of the emergency room. And then the next day, I was finally put into a, quote, hospital room.
Carl,
We're just so overwhelmed.
I think you got to tell Tagawa, if this is the way you treat your trial patients, we're going to let people know that this is not a great place to do a clinical trial. I think it's not like it's like on Yelp, right? If you or TripAdvisor, you don't want to get tripped to that hospital if this is the way you're going to treat you. And
we had a detailed conversation about that. I said, look, I'm participating in a trial. Isn't there any, do I get a little bit of extra, care? And he said, no, we're a big hospital. It's no surprise that there was a homeless person next to you. And he said they are so overwhelmed with COVID and they're just barely surviving.
Well, look, we could spend the rest of the session on this, but we've got to move on. But I think the takeaway for you is you've got to speak to somebody other than Tagawa about the sense of doing another round of pembrolizumab, and you've got to question whether this was an unidentified infection that cleared itself up, or a cytokine storm. And you've got to see how likely you are to respond to the pembrolizumab like that one more time. I hate to say it, but it could kill you.
Very sensible, Rick.
Yes.
Thanks, Dr. John. Okay.
Thank you.
Let's talk to Al Latimer and then to Dennis, because those are our two Lutetium-177 men. Al, fill us in. You're muted, Al. You'll have to start again.
Okay, there we go. Sorry.
No problem.
Maybe I'll just start with the short version. I started Lutetium-177 at UCLA July 1st. My PSA at that time was 60. I've had 2 treatments now, and my most recent PSA a couple weeks ago was 3.5. So my PSA has gone down like 95% in less than 2 months. I have another treatment this coming next week, and I've had minimal side effects so far, other than the cost of going back and forth between Florida and Los Angeles. I'm beginning to experience some dry mouth, but that's really about it. Otherwise, I'm feeling pretty normal. This is after, I don't know how many of you know, but I was first diagnosed in 1995, so that was a long time ago. I was on Lupron for a long time, and then estrogen, and then I added Xtandi, Zytiga, Nubeqa, Lynparza, and one after the other. I eventually failed all of them. And I started with this group about a year ago now, and somewhere along the line, they recommended I have an appointment with Dr. E at that time, MD Anderson, and she said, well, the first thing you have to do is go get a PSMA, go do the PSMA PET at UCLA, which I did this past February, and then in April, Dr. Scholl said they were opening up this lutetium program at UCLA for compassionate use for people that had failed other therapies, and I applied for that and got accepted, and you know, it's been a miracle that that I've had this kind of response to it. My PSMA PET showed multiple lymph node involvement, but no bone. Even when my PSA was at that time was around 30, no bone involvement, no organ involvement, just lymph nodes, mostly in the abdomen and some in the chest and one in the neck. I don't know, Rick. That's kind of a real short version. Do you have specific questions you would like to ask?
Good for a guy's over 100 years old. You've had it for 26 years? Really? How old were you?
That is correct. I've had it for 26 years.
Wow.
I was 47 when it started.
Holy moly.
I'll tell you one thing, Al. You look like $1 million. You look healthier. Your face looks healthier, fuller.
Maybe it's just psychological. I mean, when you have your PSA going up every time you take a test and you don't have a good solution for it, I mean, it's draining. How long were you on Lupron for, Al? I was on Lupron alone for about 9 years, and then I changed doctors. I went to Dr. Myers in Charlottesville, Virginia, and I was telling him how much I hated the Lupron, and he said, "Well, I think we can get a similar response with estrogen." So he switched me to estrogen, and it was a miracle, the difference, the way I felt from it. And I was still getting control of my testosterone. And that went on for another 7, 8 years, I guess, before my PSA started ticking up. He added Xtandi to it. And that dropped it back down to undetectable for a while. And I hated the side effects from that. He took me off of it. My PSA started going up again. I went on it, off it. Eventually it stopped dropping it again. And I tried a few other things. So yeah, 26 years of this and that.
Have you had genetic testing?
Yes, yes, and I was BRCA2 positive. I was on Lynparza for 2 years. It was effective for a little over a year, and then it started failing. The only thing I hadn't done yet was chemotherapy.
It's great to hear a BRCA2 person that's lived this long, I'll tell you. I'm one also. So what's your Gleason?
My original Gleason was 5+4.
Oh, God.
My PSA diagnosis was 19.
Oh, boy, you give me a lot of hope.
So you have to understand, in 1995, there was no internet. There weren't a lot of support groups. It was really tough trying to figure out what to do. Maybe that made it easier because there wasn't as many choices. But I ended up having the surgery at Johns Hopkins, and I survived that. I survived. I was not incontinent, and I was not impotent afterwards.
So let me cut in a little bit because I'm sort of got one eye on the clock here.
So
the question I wanted to ask you, because it's pertinent and a segue to Dennis, is do you know what your dose of lutetium is each time?
I don't know, but maybe I can. I don't know offhand, but I probably can look and see.
That would be great, because I think as we'll hear, it may be pertinent to Dennis's experience. And you've never had chemo, Al?
No, I had not yet had chemo.
So that is really interesting from the standpoint of getting compassionate use approval, because we know this managed trial now that's coming together is requiring, which is a sort of compassionate use managed access trial, is requiring chemo.
Well, UCLA is now requiring chemo too. It's just,
okay.
I got in it, so I got it in it early, and they weren't requiring it at that time.
Okay,
and
that makes sense.
They also thought because I had no bone mets that I was really a perfect candidate for it.
Okay.
And so, but I saw the doctor when I was there in August, and he told me they wouldn't accept me if I applied now because I had not had chemo.
So Dennis, why don't you talk a little bit about your experience, and then we'll just open it up for the lutetium questions.
Sure. Well, I gave an update last week, but I'll just give a recap tonight also. So I started my lutetium trial in March, and I had 3 treatments. Had a good response during and while I was on treatment. My PSA declined by like 75%, and my lymph node lesions improved. But shortly after I stopped the treatment, like 2 months after I stopped treatment, my PSA started going up. So essentially, 2 months after I stopped treatment, my PSA more than doubled. And there was some activity in the lymph nodes again. So raised a lot of questions about the design of the trial with 3 treatments versus 6 treatments that the VISION trial was. So that's the update.
Anything since we spoke last week with respect to talking to Dr. Lang or Dr. Morris?
Yeah, so one of the things I've been pursuing over the last week has been expanded access or compassionate use, whatever you want to call it. And I have not had much success, mainly because those programs are for patients who don't have other options. So despite the circumstances of me just coming off trial, that did not really resonate with my doctors. So yeah, so that's a tough situation.
So what does Lang think is the next move for you?
Well, I had a biopsy on Friday. I think we want to see the results of the genetic testing to see if the cancer has changed since my last biopsy 2 years ago. So I think that's the first step. And his recommendation is to continue to look at clinical trials before we go to other FDA-approved options.
What did they biopsy? A lymph node, Dennis?
Yeah, they biopsied a lymph node in the retroperitoneal area.
Okay.
And that lymph node was one of the larger ones. It was 2 centimeters.
Success, and the biopsy was successful. They got a good sample out of it.
Yes, I believe they did.
I'm sorry.
Where are they sending it to which lab to be?
Yeah, they're sending it to Strata Oncology.
I don't think I know Strata Oncology. That's not one that's not a lab I'm familiar with at all. I'm curious why. Is that a lab that is proprietary to Carbone in medicine?
Yeah, I'm not sure. I haven't really done diligence on that, Rick.
I think you should.
Yeah.
I do think you should. I mean, you know, we know, we certainly know FMI and what's the other one? Not Clovis. What's the one, Peter, that you had one sent to?
Gardent.
Gardent 360 is another one, and then there's and the one with a C. I always forget.
Oh yeah, I can't.
Caris.
Caris, thank you, Caris. Yeah, Caris. I always call it Clovis, but Caris, Gardent 360, FMI. Those are all really valid. This one, I just don't know. I don't even know what their panel is. And so
he did. My oncologist did mention that they do follow the same panel as the impact analysis at Sloan Kettering.
Okay. And how long do they take on the turnaround?
2 to 3 weeks.
Okay. All right. So anybody got any questions to either Dennis or to Al about these lutetium trials?
Rick, I have the answer on the dosage.
Yeah.
I don't know what this means, but it says 1.99.32 small m, large C, small I.
Military.
Yours was 2.5, didn't you say, Dennis?
So mine was 500 MCI per dose.
Military.
I thought you said it was 2.5. Al was 1.99.
Times 10 to the 3?
Pardon? I mean, I'm looking at the report I got from UCLA, and it says 1.99.32, 199.32 MCI. I don't know what that means.
So that says roughly 200 militaries. If that's what it's.
I'm scheduled to do 6 doses, 6 weeks apart.
That to me sounds like what the Vision trial was.
It is supposed to it's supposed to mirror the Vision trial, yes.
Yeah, 200.
Novartis is donating the product for the compassionate use. And I understand that Dr. Scholes has referred 5 or 6 of his patients now into this program.
And so that's 200, and you were getting 500, you said, Dennis?
500, and that was part of the reason why I had 3 treatments versus 6, because they wanted to control the total amount of drug.
Okay. We're gonna keep moving along here because we've got a lot of people to get round, and we've got someone else coming into the room at about 20 after the hour. So we'll push as hard as we can to get through everybody. Yeah, let's see what the next generation sequencing produces, Dennis, and we'll all put our heads together and see what we can come up with. And you know, it may be that you've maxed out on the amount of lutetium. I've never We've never had that conversation, and I don't know if there is a max or not. Herb may know, or Len may know.
Did either one of you have any side effects from the lutetium? Nobody mentioned anything.
Al did. Go ahead, Al.
I'm sorry.
Yeah, I've had, I've noticed lately some dry mouth, which is one of the side effects. Loss of sense of taste is a side effect. Fatigue is a side effect. I haven't really experienced either of those so far. Now, Dr. Calais, who's the doctor running this program at UCLA, told me that that after the 6 treatments, if there is a reoccurrence, that they could do a second round. So
that sounds great.
I'm not there yet. Maybe I won't ever get there, but they apparently they have experimented with that. He also said that
I'm hearing the same thing from my doctors. They don't think I've maxed out on lutetium.
Okay. So guys, we've got to move along. We'll go to a real quick one next. Herb, you want to share your news?
Okay. Real quick, I had met my 3-month exam today. PSA test showed a reduction from 1.7 to 1.5. Not a fabulous, it didn't go to 0, but it's going in the right direction. So I was not devastated by the results. I was quite pleased. The other result, which is a little weird, but I guess we now know the answer, was my hemoglobin's been dropping steadily for the last year or so. And today it was down to 10.5, which is, and I've been noticing some effects of that. But then my physician said, well, let's draw some more blood. And they did all these tests related to iron metabolism. And it turns out I'm iron deficient. So we're going to start, we cut out meat. We've been eating a lot of vegetables. And so maybe that's the reason, but we actually have a bottle of iron, which I'm now going to start taking, and hopefully it'll work. So that's
okay. Questions, or can we move on? Any questions on the iron deficiency? Anything else?
It's very unusual, Herb. Are they sure you're not bleeding anywhere? Because I remember from the days when I interned as a medical technologist, the hematologist said, if someone's got low iron and a normal diet, they're probably bleeding somewhere.
Well, she asked me when was the last time I had my colonoscopy, and it was not that long ago, and it looked fine. So, I mean, yeah, she was thinking about that. But I think once once the numbers came back that all the iron numbers are really low or off, we're going to go. I guess it's prudent to go in that direction first.
Yeah. Okay. Good luck. Glad to hear the PSA is dropping.
Right. That was the more encouraging news.
Herb, did they tell you to start eating more meat?
Yes.
You said you would cut it out.
Yes, she said to eat more meat, and I guess I can't really object because even though we've tried Impossible Burgers, I really prefer the real thing.
I hear you, man.
But we had brisket for Rosh Hashanah, so
don't try and break the fast on brisket. Let me just say,
no, that would be terrible.
Okay. All right, let's move right along to Alan Moskowitz. Go ahead, Alan.
Okay, thanks, Rick. Okay, so it's a quick update, and I'll ask for sort of a point of view. My PSA has gone up from 4 to 5 over the past 3 months. As you all know, I've been sort of tracking this, and I've already had a number of years ago the prostatectomy, radiation. It's all been recurrent, slowly increasing over the past number of years. Well, this past 3-month period, it jumped from 4 to 5. And the doubling time, which my medical oncologist always asks about, is either going from 21 months to 13 months if you are looking at 9-month data, or typically it's gone from 17 months to 16 months if you look at, the past 12-month data. Okay, so regardless, it's, the doubling time seems to be on a trend going down. Now I'm seeing my medical oncologist next week, and I'm going to talk to him about, number one, I'm thinking about getting another Axeman scan this fall. I was hoping for the new Pylarify, but the Medicare is not yet covering that. And I'm not sure I want to wait till next year. The last scan I had a year ago, March, so that's March of 2020, when my PSA was only 2.3, didn't show anything. And back in November of 2019, I had an Axeman scan, a PSA around 2, and that also showed nothing. So I have not had the, I call it the pleasure perhaps of a scan that shows me something and gives me some useful information. And both my doctor at Sloan and also Dr. O at Mount Sinai have in the past said, no rush to have treatment, as long as your doubling time stays, well above 12 months, and, your PSA could go up to 5, which it is now, or perhaps even as high as 10. And so my question, I'm thinking, at some point I got to give up on the scan. I'm figuring I'd treat myself maybe to one more. And frankly, if I don't find anything on the Axeman, I'm probably very tempted to start the hormone therapy maybe next year or even late this year. Anybody have any thoughts on that? I mean, is it time? Is there a reason to keep waiting? I mean, for whatever the reason, Axeman hasn't been successful, nor the other scan. Both doctors think it's probably micrometastatic, and it's just, the cells are so small, nothing is picking them up. I'll take any thoughts.
Have you never been on hormone therapy before, Alan?
I did have 6 months of it concurrent with radiation back in 2016. It was a Gleason 4+3. Originally, my PSA went as high as about 4.5. And then on the rebound, my PSA went to 0.11 before I started the radiation. And, I've been a very slow trend since then.
So Richard G is asking why not a PSMA PET scan for Alan. Richard, the Lantheus Pylarify is a PSMA scan. It's the one that's probably most readily available right now. But the issue we're having is that, and I wasn't aware of this, that that Medicare is not covering it yet. Is that right, Alan?
That's correct, as far as I know. They need, whatever the reason, the FDA approval is not concurrent with Medicare. They need to work out the billing and the pricing and their computer systems and all that other stuff.
But
so not yet.
We definitely know guys that have had a Medicare, that have had a Pylarify test, and their insurance has covered it. Now, I can't tell you what their insurance was. Anybody on this call tried for a Pylarify test yet? No.
Rick, is your case where someone had private insurance or Medicare?
Well, they were certainly old enough to have Medicare, but I'm not sure. I'd have to go look. Whether they covered it through Medicare or not, I don't know. But we have known people get these Pylarify tests already.
And have they gotten them in a hospital setting or, research hospital setting or through a local
private radiology settings?
Interesting. Yeah, I called 2 different places and neither of them were offering it yet. I'll have to do a little bit more checking. Maybe I can find something.
Have you called Pylarify?
Yes. Yes, about a month and a half ago. And they told me that in the case of the hospital setting, they didn't think that was going to happen until the beginning of next year, meaning Medicare approval. In a local setting, they thought it was possible, and they were trying to do some test cases to see if Medicare would cover it, at least under a generic radioactive tracer, and that Lantheus was working out some arrangement to reimburse and make whole these local organizations of radiology.
So I think what I would do, especially given things are moving pretty quickly, is I'd give Lantheus a call again and find out where they're up to now. And also if they know anybody in the tri-state area that's offering this.
Okay, that's good. So one last comment then. You know, there's no way to know whether or not my cancer is a PSMA expressor. And so my question is, at a PSA of 5, don't I have a very good chance that Axemin would find something, perhaps more so than Pylarify, if I'm PSMA negative?
I would say that forgetting whether you're PSMA negative or positive, that Axemin should do a pretty good job at a PSA of 5. Yes.
Yeah, but here's the deal, Alan. Axemin is what they call a metabolic scan. So the cancer cells pick up the radioactive synthetic amino acid, fluciclovine. Now, if you have a slow doubling time, those cells just aren't very metabolically active. So that might be why Axemin is not picking it up.
Okay,
Isn't that a good thing?
Alan, this is Al Latimer. My PSA has been even higher than that, and there's still, my scan was still negative, but when I did the PSMA scan, I had a bunch of lymph nodes that lit up. So you may go, who knows how long you'll go with Axemin scan before it picks something up. I mean, I was 14 and it still was negative.
Yeah, this is a tough one. I'm gonna have to talk. I'm gonna take your advice, Rick, and I'm gonna mull it over and see if I can find the Pylarify. I just don't know which way to go, but I have a feeling it's only one more shot. Whichever one is negative, then I probably wouldn't do the other scan. I'm tempted to just start treatment and be done with it. But I'll wait and see. Okay.
Alan, how old are you? It's David Muslin.
Yeah, I'm about 67 and a half.
Okay, and when you did your radiation, you were on Lupron or Lupron before. How'd you do on it? I know it's kind of hard to tell because you were doing radiation and hormone treatment. How'd you do on it before?
Yeah, so a couple things. So I thought I did pretty good. I didn't have much in the way of hot flashes, but I wasn't watching, and I had some weight gain and I had some muscle loss, even though I was doing some exercise. So I'm not overly worried about it, although I am osteopenic already. And so both my oncologists said, yeah, you'd probably be a candidate to go on Prolia at the same time or soon thereafter. So I probably could withstand it without too much difficulty. I'm more worried about the Prolia than I am, frankly, about the Lupron.
On the Prolia, I'm not sure why Prolia would concern you. I mean, the people that we know that have taken that drug, either in the form of Prolia or Caregiver, have had very little side effect issues with it.
All right, that's good to know. The reason I say this is because I have no experience with it, okay, versus the hormone therapy, which I've done. It's as simple as that.
All right. Well, look,
Starting Caregiver pretty soon. They told me to go to the dentist.
We got to move on. Sorry,
Okay.
guys.
Thank you very much. Thanks, everybody.
Let's go to Les and then to Dennis. Les, you had something today.
Yeah, just very quickly, you had mentioned about the possibility of using this medication MYR Beckwith or whatever's.
Myrbetriq.
Myrbetriq, yeah. I did try that. Well, I tried first the pumpkin seed oil and tried that for a while. I didn't seem to notice any difference. But I did try this other drug that you had mentioned. It turned out that was the same drug that my family doctor had mentioned about 6 months ago. So I did try that, and it does seem to have made some difference in my frequency and urgency and all that sort of stuff. It has helped. You know, I was to the point before I had to, I know Jerry had mentioned about having to get up every 2 hours. Well, mine's been about every 1, but it's increased some since then. The other thing you know, I had mentioned when I spoke one time before, my PSA had been 0.1, you know, 0.1 for a long time. And it finally jumped up to 0.4. It's hasn't increased at that rate. It's up to 0.5 now. So it's still going up, but it's not at the terrific rate it had to start out with. That's about it.
So, anybody, first of all, want to talk to Les about the urgency issues? Who was it that recommended the pumpkin seed oil?
We never, well, I don't know. I remembered hearing it, but I never, even when I played the recording back, I couldn't catch who it was.
That's right. That's right. That's right. So we don't know who mentioned the pumpkin seed oil, but it doesn't matter because it didn't work that well anyway. So it's just as well we don't know, Les.
Yeah.
But we're glad the Myrbetriq seems to be working. Anybody else want to comment on Myrbetriq or frequency issues? Okay.
I don't know if Jimmy has tried that. Jimmy Greenfield, he was in on that conversation originally. He had some similar issues, not quite as significant as mine, but it was.
Right. Jimmy, are you there? Are you there, Jimmy? Your microphone's off and we can't see that smiling face anymore. But we know you're back home in your studio.
Right.
I think he must have stepped out.
Yeah.
Last, I'm a 2-hour guy myself, this is Peter. But anytime I've noticed when I'm not feeling well or something else is going on in my body, you know, low-grade fever, or just not feeling on top of my game, I go back to 1 hour urination all night long. It's pretty common for me sometimes.
Oh, yeah. Okay.
Normally, I'm just 2 hours.
And Peter, are you taking anything?
No, I don't take anything. No.
Maybe you want to try Myrbetriq. I forget, what's the other name for Myrbetriq? What's the I think Myrbetriq is the trade name. What's the chemical name, Len?
Sorry, Rick, I don't recall.
Okay, all right.
Do you drink or use medical marijuana or any kind of marijuana? How about alcohol?
No.
No, okay. I've noticed it. I rarely drink, and I don't smoke grass much, but when I do drink, I notice I can go sometimes 3-4 hours at night without peeing.
Really?
Yeah, it's amazing.
You mean drinking helps?
It helped me, yeah. I don't know why. Now, I'm not talking about downing 100 beers. I'm just talking about, you know, having a glass of wine or something before bed. Yeah.
That's interesting.
Yeah.
Mirabegron, that's the name of that's the name, doesn't really matter. Okay, and the issue about your PSA rising, we're delighted that you're getting better sleep, but we're not so happy to hear about this PSA rise. What's your thinking on that? Have you set yourself a limit? Are you going to go back on hormone therapy? What's the story?
Well, we don't know yet. I've got an appointment to go back up to Mayo. The earliest they could possibly squeeze me in was middle of October. Doc wanted me in September or October, and then they told me the earliest they get me in was November, but they must have had a cancellation and got me in, I think it's the 14th of October. I had talked with Len about, was it darolutamide?
Yeah.
Len, that'd be a suggestion that I'm going to propose. Well, had proposed to him, and he said to Dr. Kwan, and he said, well, we'll wait until we see the results of the PET scan before we even discuss it.
Have you, you're still on the Eligard. You went back on the Eligard and you're still on it, right?
Correct.
Yes. And have you thought about, again, having a different type of scan? Although 0.05, it's not going to show too much, but you're getting to the point where something may show.
Yeah, I was figuring possibly by the time I would get up there for the test that it would probably be up high enough. That's the way it's worked in the past anyway. By the time I got there, it had risen enough to show up on the scan.
Okay. Well, keep us posted. There's not much to do right now.
Well, right.
Right. So, Dennis, Korea.
I'm here.
You
and
are.
Just continue my journey back to treatment from my drug holiday, and just update just since our last call on last Monday. I'm back on my LHRH. This time it's going to be Eligard. So I got my first injection with Eligard. And I've had a review of the my new biopsy of the tumor, my primary tumor on the prostate. And that has come back with not too many surprises. This is not the somatic thing. This is just a general pathology on it. And it's at 4+5, grade group 5. And there was one other, the second tumor bigger, it was a 4+4, 8 grade group 4 on it. And it did confirm on the first one, the larger one, there is some perineural invasion present, which we probably figured that out anyway, because that's when it goes to the nerve and can be transported to other places, which it has done with me in the past. So the big thing now is they took 9 samples out of the tumor course, and that's going to Caris Life Sciences up in Phoenix for the somatic mutations and other things that they do with it to determine the best possible treatment type paths from here. So it's kind of a dual path right now, just looking at, what else I might need to do. My PSA is at 11.4.
So I have a question. I do have a question for you. Did they not put you on bicalutamide before they restarted?
No. I was never on bicalutamide.
To me, it's criminal that they do this. I cannot see how they can give a man with a history of metastatic disease an Eligard shot without putting you on bicalutamide for 10 to 15 days first. And to me, I would fire whoever did that. I would never go back and see him again, because they don't understand your disease. Let me explain to you why I say that. You've heard many men here get their ADT shot. Before they do it, they go on Casedex or bicalutamide. And the reason they do it is because it's a buffer. And God forbid you've got metastatic disease somewhere that we don't know, that initial shot, which will raise your testosterone to begin with, can cause significant side effects, including spinal collapse. And that's the reason why, if you're giving an agonist, you always give bicalutamide first. For some reason, these oncologists forget that you are just the same now as a new man because you haven't had an LHRH drug for the last year.
You know, I brought that question up too, Rick, regarding the possibility of a testosterone bump in a tumor flare. And matter of fact, I brought that up with Dr. Singh. When we had our initial discussions of when I had come back from UCLA, and he did not think that I would have a tumor flare. Did not suspect. I raised a question about it.
Well, I got to tell you, I would not go back to a doc that didn't prescribe bicalutamide after putting me back on an agonist when when I have metastatic disease. That's just me.
Yeah.
I just wouldn't do it. How can you take that chance? Why do they give it to you if you're brand new and they don't even think you've got metastasis?
Right. I mean, Rick, they can
Well,
have
they had the PSMA scans, and that gave them a pretty good idea of where my cancer was. That was done first.
But they have, if you are brand new and you're going on it for the first time, they can't, they're concerned that there's micrometastatic disease somewhere that could flare up and cause a problem. But that maybe that's just me, but I just think it's not standard of care. Standard of care is you give bicalutamide before you give an agonist.
I mean, or any antagonist. I mean, they could, these days you could give 5 Orgovyx and then.
Well, that's right. He could have given you Orgovyx, he could have given you Firmagon, but he chose to give you an agonist. And if he gives you an agonist, he doesn't know where that metastasis is. So for the rest of you who are on here, who are on IHT, if it were me, I can't give you medical advice, but I can tell you, if it were me, I would absolutely insist that if I was going to get an agonist, Lupron, Eligard, Zoladex, Trelstar, I would want 10 to 15 days of a Casedex bicalutamide beforehand, just to be safe. Just to be safe.
So, yeah, you know, I had Firmagon when I first started. They didn't stop me right on Lupron.
Right. If they give you the Firmagon, they don't have to give you the bicalutamide.
Yeah.
And it just really, really bothers me. Anyway.
Okay.
Well, hopefully you'll do just fine on it. You'll feel fine, and you know, that's about it.
Yeah. And I did today my first SBRT on the bone metastasis.
Sacrum.
Okay.
On the sacrum. And that was pretty smooth and no problems. I was here locally in Tucson. And I got 2 more days to do on that one. And then next week we'll start on the prostate.
Okay.
The only other thing I say, I did the PCRI conference this past weekend. I thought it was excellent. A lot of information to try to digest, getting thrown out pretty fast, but nevertheless, I think it's, you can if you didn't see it or didn't participate, I think there's a recording, you can get it, go back and listen to it. And basically, I thought it was pretty good. And the other thing I did was I've gotten my third COVID shot from Pfizer. There was something that I'd read about. It was an observational study where men with low testosterone levels were having significantly bad effects if they got COVID. They were getting, most of them were going to be intubated, and the number of deaths were higher. However, it was observational, Herb, it was not clinical trials. So there was no separation for age or other parameters and stuff. But anyhow, I said, if I can get the third shot, 76, getting this treat, starting all these other treatments again, I'll get it, and I got it. So,
I mean, let me just interject that my MO today, we talked about the third COVID shot. She thought I should get it. My own sense is I just heard a long presentation by Tony Fauci and Francis Collins, basically saying that the data aren't quite there yet that say we need it. So here again, the data are not clear. We had 2 guys from the FDA resigned because they felt that the booster shot was premature. So, I mean, I think obviously you can always say it can't do much harm, which is true, and it does raise your antibody levels. But whether we actually need it is something that's not clear.
Yeah.
I just got a message from Mayo Clinic saying they recommended it for people like me.
Yeah, I did review
I
it
heard
with
Fauci say today that he did think that the data will confirm that you do need a third shot. This morning on
Right. The data weren't there on Friday when I heard him, so.
well, I'm just saying, he said it's not conclusive yet, they're studying it, but he thinks that's the direction it's going to go in. Somebody had an article that said something like that. He said it's not conclusive yet. I got the shot, and I'm happy I did. So the third one, Pfizer.
The early booster is available if you have a tumor. That is one of the requirements for getting shot early. So if you have a tumor, which anybody with metastasis has, you can get it legally under their requirements.
Yeah, you have to fill out a little paperwork thing, and basically I put down on there, stage 4 metastatic cancer, and that was it. No problem. At Walgreens, walked right in.
Right.
Down.
So we're going to have to close up pretty quickly. Just a couple of quick things here. I do want to talk to Carl. Are you still? Yeah, you are still with us. Carl sent me a note in the chat that he heard back from Dr. Tagawa. The genetic test that he's talking about is not the genetic test that we're talking about, Carl. The genetic test that Peter gave you the name of is something completely different to the somatic testing that Tagawa is referring to. So, you need to clarify with him that the genetic test you're looking for, if it is a genetic test, I don't know what it is, but the test you're looking for is, Peter, what was it called?
IMUDEX or something like that. IMUDEX or something.
Yeah, IMUDX testing. That's what you're looking for. Nothing to do with the BRCA2 that he's referring to. So I would certainly clarify that with him. And the rest of what he says is exactly what you'd expect him to say. He doesn't think that that it was a result of the pembro, and we'll watch you carefully. And again, I just say one more time, if it were me, I'd get independent review of that test just to find out. I saw somebody come on very briefly. It might have been one of our early MS guys. Is there anybody that has anybody? I've tried to get around everybody. Is there anybody I've missed who has anything they want to raise for this session before we close out in the last couple of minutes? Did everybody get a fair hearing? Okay, I see a couple of thumbs up. So next week, we will be in Herb's capable hands with either a plum or a banana or something. I'm not exactly sure what. I'll be in touch. I'm trying to think if we've got any important announcements. I don't think so. We've got a couple of webinars coming up at the end of the month. If you did not hear the layman's guide to medical research that we were talking about at the beginning, it's probably worth listening to. It's on our blog. You can get it, or if you just Google it, you'll find it on the blog. If you didn't hear the managing your medical team, it's not what you're going to expect. We're not sitting there telling you all of the specialties you need to go on, but it is an amazing, amazing webinar, because you're going to hear doctors tell you about how they respond to their patients and what they expect from their patients and how they see their patients. And if you listen carefully, it might give you some good pointers in how to deal with your doctors. They were amazingly frank. And we've had some feedback that people didn't like the webinar. I think it was because we didn't give you 10 points of advice you can take home, something you needed to listen to. But I've never, ever heard doctors speaking so frankly about how they deal with their patients and how their patient relationship. So that's about it for now. Maria, how is that? How is that steak, that beef stew? You're
Which
muted.
webinar was that, Rick?
I'm asking Maria how that beef stew was. Good?
Almost done.
Almost done. Okay.
I'm patiently waiting.
Okay. That's
Rick, what was the name of the webinar you were just talking about?
Well, I talked about two. One is a layman's guide to medical research language, and the other one was called Managing Your Healthcare Team.
Right, that's the one. Okay.
Right, and we will visit that again next year, and we will give you the information you want, which is the type of doctors you want on your team and what have you. But sorry we didn't give it to you this time, but what you got is something we could never have planned. Never, ever, ever have planned. It's a pretty amazing, it's a pretty remarkable webinar. So at least I think so. That's my view of it.
Is it still up, posted somewhere where we could listen?
It's on the blog. If you're not,
okay, yeah, I haven't been going.
Sign up for the blog. If you just go to our website and search for that title.
I think I saw it. I'll find it. Thank you.
Okay. All right. Good night, everybody. Take care.
Good night. Thank you all.
An easy fast to those of you who are fasting on Thursday, an easy fast.
Thank
Bye.
you. The same to you.